Hello dear guys, today we're going to discuss the female reproductive system, histology. So today we will discuss all the structures, so we will discuss some parts of anatomy and physiology too, but mainly we'll discuss the histology of reproductive system. So components are paired ovaries, paired oviducts of fallopian tubes, uterus, vagina. So functions include produces female germ cells like ova, produces female sex hormones like estrogen and progesterone, receives sperm, site of fertilization, transports female germ cells, sperm and conceptus, houses and nourishes conceptus during pregnancy, expels fetus at parturition. So here is this diagram of anatomy of female reproductive system. So here is an ovary, here is a fallopian tube, this is an uterus, cervix of uterus, and vagina. I hope nothing new for you is this. But let's discuss in details. Ovary. So ovary is a paired organ, so it possesses two functions, both endocrine and exocrine. Exocrine function is an excretion of ovum. Endocrine function is secretion of two main hormones, is estrogen and progesterone. But other hormones are also produced there, but mainly these two hormones. So take a look at this histological structure of ovary. So you see it consists of tunica albicans and epithelia, which is present here. So epithelia which is present on the surface of ovary is known as mesothelia. It's cuboidal epithelial lining. So you see they are cuboidal in shape, but they are derived from mesothelium. It's same epithelia as present in peritoneal cavity. But here it's cuboidal, unlike in peritoneum, it's simple squamous epithelium. Okay, and later, so below this cuboidal epithelia, we have tunica albicans. It's a connective tissue layer. We can say it's dense, irregular connective tissue. It's like joint of this ovary, by which it joins to different organs, not to join to in their place in pelvis. Then we have cortex region and medulla region. So medulla region. So we'll start with medulla. So medulla contains blood vessels, arteries and veins, lymphatic capillaries, nerve intake to this. Another name of this is mesothelium, so where it's initiated and it enters into the medulla of ovary. In medulla of ovary we also can see some atretic follicles, so it's a very boring part of structure, so nothing specific is present here. So only connective tissues, blood vessels, and everything which is necessary to sustain the function of ovary. And the main function of ovary is focused in cortex of ovary. In cortex of ovary composed of follicles. So that's follicles. Which follicles we should discuss? There are primordial follicles, smallest structures, then primary follicles. So we have early primary follicles and late primary follicles, then secondary follicles, tertiary follicles, and quaternary follicles, or another name is a Graafian follicle. It's a mature Graafian follicle. What is it? We'll discuss a little later. Okay, later these walls of the Graafian follicle they can be changed. They are changed due to some hormonal issues, hormonal features. They are changed into the corpus luteum, and later degeneration of this corpus luteum leads to corpus albicans. So same thing in details we'll discuss a little later. So cortex discussed, follicles progress, corpus luteum, atretic follicles, follicles albicans. We discussed it in general. So this is histological structure. So this is germinal epithelium. It's mesangial, mesothelial cells, but they are cuboidal in shape germinal epithelium. This is tunica albicans. Tunica albicans connective tissue layer below the germinal epithelium, and here we have a cortex. Which are present with primary follicle, secondary follicle, and granulosa cells, so follicular cells which are present here, and ZP means zona pellucida. Okay, tubicanthema, granulosa cells. So okay, we'll touch it a little later. Okay, let's start the process of oogenesis. So now we concentrate our attention on oogenesis. So, and we discuss, and you from biology and from histology of previous of the first semester, I guess you discussed what is the oocyte. So that oogenesis starts with oocyte. So actually even earlier. So let's make some embryological review of this. So oogenesis starts with oogunia. Oogunia, it's a fetal ovary. So present in fetal ovaries, this is a cell which primarily associated with the yolk sac, and from yolk sac this oogunia transports to the genital ridge, and in genital ridge it settles and continue maturation till primary oocyte. So oogonia is a mitotically active cell. So it mitotically divides, so multiplies and can be reproduced. But oocytes is the final stage of oogonia, primary oocyte. It's impossible to get mitotic division anymore. So it's possible only for meiosis. So I hope you remember the difference. So oogonia, they don't replenish their own cell life. So amount of oogonia, so which were produced in fetal period, is a constant amount. So if they came to primary oocyte, they are not producing more cells, and that's why you know this this conception of menopause. Menopause when our body is run out of primary oocytes, and we have nothing, we have no follicles, no oocytes to get matured during the menstrual cycle. So that's a feature you should keep in mind. Primary oocytes. So primary oocytes, they are present in adult women, and it started from fetal life till the menopause. Most of oocytes are present. So most predominantly we have primary oocytes in ovaries. Primary oocytes are they. So maybe here we have no. So primary oocytes are so they are resting in a primary oocyte for a long time. So from fetal life till the menstrual cycle. So primary oocytes are stored in primary oocyte stage without progression. So only activization of this primary oocyte by follicular cells which are present around, actually deactivation of deactivation. So I mean, so actually these follicular cells which are present around this primary oocyte, they produce some special chemicals which prevent the growth of this oocyte, prevent the meiotic division of this oocyte. Okay. During the follicular stimulation hormone, these follicular cells are starting their development, and they stop influence to the primary oocyte. And primary oocyte, from the phase of dic-13, so continue their meiotic process. So all the primary oocytes are resting in this dic-13. And this dic-13 phase, after the dic-13 phase, when dic-13 phase, after activation of follicular cells, it starts their meiotic process. And meiotic process is characterized by migration of nucleus to the cell surface. You see, it's primary oocyte. It is it's not divided yet. It has 2N components, 2N genetically. Yeah, so it's like usually somatic cell, like every somatic cell of our body. It's oocyte, primary oocyte. And then then starts the first meiotic division. So first meiotic division, it's conversion of primary oocyte into the secondary oocyte and first polar body. Okay, let's discuss a little later. So first meiotic division happens even without fertilization. So in every menstrual cycle, few cells undergone the first meiotic division. So we discussed the primary follicle. So primary oocytes are resting in primary oocyte only before its first meiotic division, and after the first meiotic division appear secondary oocyte and first polar body. So this first polar body, it has no role, no any specific role, so it's just residue which is necessary just to store the genetic material, excessive genetic material, one of n's. You remember that there are two n in primary oocyte, but secondary oocyte undergoes the first meiotic division. It contains only one n, means 23 chromosomes. Okay. Secondary oocyte, 23 chromosomes are present, and then secondary oocytes, they are resting in metaphase position. So they are resting in metaphase position for a long time. Yes, you see, this is first polar body, and this is metaphase plate. This metaphase plate is necessary to so it's storing in this position before fertilization, and only fertilization, only a centromere of spermatozoid and sperm cell, it activates this second meiotic division, and after the second meiotic division we see the ovum. You see impregnation of oocyte and resumption of second meiotic division happens, and centrosome of spermatozoa. So it leads to nucleus of sperm cell. Here is unpacking, and here second polar body forms, and genetic material of ovum, which remains in ovum, gets first of all packed, then unpacked, and then it leads to formation of male and female pronuclei, which fuses and directly forms the metaphase plate of zygote. And here we see three polar bodies. Okay. Ovum is a mature haploid germ cells. Haploid means 1n, and even after the second meiotic division. It happens only in fertilization. So ovum never appears before fertilization. So that's a very common confusion of students. Yeah, that ovum is not appeared before fertilization. Ovum appears only after fertilization, because impregnation of spermatozoa, so impregnation of sperm cells, is necessary to complete the meiosis, second meiosis of the ovum. So now let's talk about follicles. So here they are. They are primordial follicle. It contains a primary oocyte, as we discussed before. Follicular cells from a simple squamous epithelium around the oocytes. You see. So now I'll show it to you. So here we see we have very. So this primary oocyte is cuboidal epithelium around, but in primordium follicles we have simple squamous epithelium. Primordial, and is the only follicle present until puberty. These follicles, they have potential, but they are not active. They have potential for division. Then primary follicles, that's the next stage of follicle progression. It's a primary follicles. It's a primary unilaminar follicle. It contains a primary oocyte. It is primary oocyte inside, same as in primordial follicles, but follicular cells from a simple cuboidal or columnar epithelium around the oocyte. They become, so as is shown on this diagram, cuboidal to columnar shape. It was stimulated by follicular stimulation hormone. You see, simple squamous epithelium is very thin epithelia, yeah. So on here it became thicker, just because of FSH core. Sorry, my face is jumping. Okay. It's a primary follicle which contains primary oocytes. So please don't confuse these conceptions of oocytes and follicles. They are different. Oocyte is one cell. Follicle is a group of cells. So with oocyte and cells which are present around. So then we have multilaminar follicles. Primary multilaminar follicle. So in some Some books concerned to make it like different types of different type of follicle. Somewhere they name still primary follicle. So let's clear that. So what is a primary multilaminar follicle? It's also containing primary oocyte. Follicular cells, which are present around, form a stratified epithelium around the oocyte. So here it's not shown, but just imagine. So instead of one layer of cells, follicular cells, here around we have a multi-layered epithelium. So it is shown on in this diagram. Yeah, primary oocyte, primary follicles. They contain multiple mass of cells. So you see, it's multiple layers of follicular cells, multiple stratified epithelium is present. Okay. Then, zona pellucida, formed by both the oocytes and adjacent follicular cells, is a thick glycoprotein band surrounding the oocyte. What is the zona pellucida? So here is ZP, zona pellucida. Zona pellucida is by thickness, it's by their properties, it resembles the cartilage. It's a thick membrane which contains a lot of collagen, which is and you remember I said it in the beginning. Yeah, follicular cells, they promote inhibitors for oocyte. Primary oocyte, it prevents division in secondary oocyte. But here, this zona pellucida, it like insulate these chemicals produced by follicles, follicular cells to oocyte, and this oocyte became not influenced by these follicles and independent from it. And as well as it gets independent, it converts, it continues the process of cell division, continues the process of meiosis, and this primary oocyte continue their progression into the secondary oocyte. So zona pellucida, so formation of zona pellucida is very tightly related with transformation of primary oocyte into the secondary oocyte. And then, yeah, here is it. So you see it's primordial follicles, simple squamous epithelia present around. No, zona pellucida is absent now, and this is primary oocyte. Okay, annulate lamella, so it doesn't matter for us, mitochondria, and this is their follicular cells. But then, under influence of follicular stimulation hormone, some of these follicles, these follicular cells, some of follicular cells, yes, of some follicles became cuboidal to columnar, and even after columnar, it become multi-layered. It's a secondary follicle. So, okay, it's a late primary follicle. So you see, they are surrounded, and then later, so you see, we have first attempts to form zona pellucida. It's not zona pellucida yet. It's just connective tissue fibers are embedding here, but they are not too thick to insulate the influence of follicular cells to oocyte. But here we have secondary follicle. So let's talk about properties of secondary follicles. They contain the primary oocyte. Follicle cells increase in size and number and produce a follicular liquid. So what is this follicular liquid? We'll discuss later. Follicular liquid accumulates in antral spaces between follicular cells. Multiple antral spaces eventually coalesce to form a single antrum. And granulosal layer, granulosal cells or stratum granulosum are follicular cells surrounding the antrum. So you see, these follicular cells, they are converted into granulosa cell. Granulosa cells, they are endocrine active cells. They surround the antrum. These cells convert androgens produced in the theca interna into estrogen. And cumulus oophorus is a hillock of granulosa cells in which the primary oocyte is embedded. The innermost layer of cumulus cells immediately surrounding the oocyte forms the corona radiata. Take a look here. So they were follicular cells of late primary oocyte. Yeah, so you see multiple epithelial lining, and these cells producing the liquid. Yeah, and they produce liquid between the cells. So you see there are large gaps between different cells, and forms something like cushion. So it's shown here like cushions. Yeah, and some of this liquid became interconnected. Yeah, so like droplets of water, they located together. Connection between epithelial cells here, between follicular cells here, became weakened, and due to this, it makes bubble. Yeah, so it is collected in one bubble. This bubble is named as antrum, filled with water. Water and other components of plasma components plus hormones which are present here and produced by granulosa cells, and so they are present in this location. And you see, zona pellucida gets very thick, and influence interrupted from these granulosa cells to this oocyte, primary oocyte. Okay, and also which structure you should also be concerned about. So here we have a epithelial. So as every epithelial lining, as granulosa cells here, they have their basement membrane or basal lamina, and cells which are present below this basal lamina, they are known as granulosa cells. And cells which are very closely adjacent to this basal lamina, they are known as theca interna. Theca interna cells. They are not epithelial cells, but they are very actively hormone-producing cells. Theca interna. So, and everything which is present above this theca interna is known as theca externa. And they are also hormonally active cells. This histologically it matters, physiologically it doesn't matter too much. Okay, let's continue. Then, okay, mature Graphene follicle. Somewhere you can hear this. It's a tertiary follicle, somewhere a quaternary follicle. So classification is unclear because it's different in different books. I recommend you this classification. So now I'll show you again. This classification is primordial follicles, early primary follicles, late primary follicles. So difference between primordial follicle and primary follicle is the epithelia which is surrounding it. Primordial follicle have simple squamous epithelia. Here we have simple cuboidal to columnar epithelia. Late primary follicle, it possesses stratified epithelia, stratified lining, and then when we have liquid gaps between the cells, it is a sign of secondary follicle. When antrum is formed, we name this follicle approaching maturity or tertiary follicle. And this follicle approaching maturity, so later converts into Graphene follicle. And this is sometimes its name is quaternary follicle, but more commonly its name is Graphene follicle. Okay, let's continue. So let's talk about Graphene follicle itself. So you see, I remind you, in this diagram formed antrum. It's just meshwork composed of liquid, some dead cells, but mainly liquid which is produced by this liquid producing cells. They're glandular epithelia, yeah? And they excrete something, and they excrete it inside and form this cushion. And in Graphene follicles, this matrix became very large. It also happens under the control of follicular stimulation hormone, FSH. And you see, it forms two, and these cells which are present around, as they are not named as follicular cells anymore, they are named as granulosa cells. And these granulosa cells which are present around, they still remain to be granulosa cells. And cells which are present here around the ovum, around the secondary oocyte now. So actually here it gradually converts into secondary oocyte. This process, you see, it's independent from each other. So secondary oocyte follicles, they are independent. But one thing which connects them together, it's a possession of the zona pellucida. If zona pellucida is built up, so the process of meiotic division continues. And these cells of granulosa, they are known as cumulus oophorus. So I said it before, cumulus oophorus, which later become corona radiata after the ovulation process. So this is schematic image. This is the real image. So cumulus oophorus is this portion of granulosa cells, and here it's a granulosa cells, so which later become spoiler, it's a yellow body. Okay. Also, you should remember that around this we have theca interna. And theca interna is responsible also for estrogen synthesis. And theca externa also here is just for supportion of the structure. So in this Graafian follicle, it's a very large structure, sometimes reaching a few millimeters, 4 to 5 millimeters, and it can be ruptured. It's visible with naked eye structure. And what happens during the rupture? Let's model this situation. Yeah, it ruptures. So what happens? So actually, these cumulosophorous cells, they have very poor connection to the rest of the epithelial cells, because they're producing the liquid. Yeah, they're producing the they discharge the cells from each other. And after the rupturing, what happens? So these cumulosophoric cells, they distend from the rest of follicle, and ovum surrounded by cumulosophorous cells flushed into the fallopian tube. And this process name is ovulation. Ovulation happens almost all the time at day 14 of ovarian cycle, almost every time. So it's this first process of this first 14 time. So 1 minute. This process of maturation from primordial follicle till Graafian follicle lasts for 14 days, and very rarely it shifts to one day further, one day before, but mainly in most of females it's 14 days. And ovulation, so why I pay our attention to this? So 14 day is the main day of fertilization. So when a risk or chances of fertilization are maximum. Yeah, for someone it's risk, for someone it's a happy moment. Yeah, so it depends on people, depends on situation. But anyway, 14 day, the chances of in 14 day, and actually more in 15 day. I'll explain why. So the chances of fertilization is the highest. Chances highest. So because of what? This oocyte, which is surrounded by cumulosophorous, they're transported through the oviduct to the ampulla and to await fertilization. So this process of transportation lasts for approximately 1 day. And fertilization usually occurs not in ovary but in the ampulla of fallopian tube. That's why 15 days, so day after ovulation, it's the greatest chance for fertilization. Later, chances are reduced every day, so significantly. So most of cases of pregnancy, they happened in 14, maybe 15 days, not later. So fertilization triggers the completion of meiosis second and the formation of an ovum. Okay, so fertilization. So only in fertilization, secondary oocyte converts into ovum, and then ovum immediately converts into the zygote. So that you should remember that ovum is a very short stage. Okay, and but now we should be concerned about follicle wall. So follicle wall continues its conversion to a corpus luteum. So under the influence of which hormone? Of course. So you are not here. So luteinizing hormone, corpus luteum, luteinizing hormone. So in all these follicular cells, all these granulosa cells, under this hormone, they undergo some epigenetic changes, and this from granulosa cells it converts into the luteum cells. This luteum cells is named luteum, means yellow, and they are like became yellow in color, and due to this yellow color, due to some biochemical changes, it is responsible for secretion of more progesterone. Before ovulation, we have much more estrogen in our ovaries, but after ovulation, so it gradually converts into progesterone. It has a very important role in menstrual cycle regulation. So, but now just remember it. So, follicle wall continues its conversion to corpus luteum, as I said, under the influence of LH. Ovulation is stimulated by a surge of luteinizing hormone. So, you see, ovulation itself is is determined by luteinizing hormone, and a conversion of these follicles into the corpus luteum is also controlled by the luteinizing hormone. And we a little bit discussed it in endocrine system, that luteinizing hormone is produced by anterior portion of pituitary gland. Atretic follicles. What are atretic follicles? They are those follicles which are not going to be fertilized, not going to be even ovulated. Yeah. The process of oocyte follicular atresia begins before birth and continues throughout the life of a woman. So you see, there were produced approximately 2 million primordial follicles. 2 million, just imagine. So it's enough to live for 1,000 years, yeah, for 1,000 years of menstrual cycle. But they are gradually get at rest, and that's why at birth remains only 45 legs, yeah, of oocytes, and at puberty it remains only 450 only. So you see, 1,000 times less than after birth. So why nature made it like this? Because nature doesn't care about persons who is older than 45. Yeah. So that's why 450 is more than enough for every menstrual cycle of female's life. So which are started from 13 years, and you can count, yeah, 13 years every month, one menses. So how many ovulations you need. So of course it varies in every person to person. So it for some of them we can simulate. For some we can actually pharmacokinetics right now. So we can simulate these menstrual cycles. To make it even more, even without these follicles. And actually in every menstrual cycle, in ovulation process, it starts the normal menstrual cycle, not only one of these 450 follicles, but sometimes few of them. But during this during the process of progression of this, some of them wins, and dominant follicle only wins, and non-dominant so remains unchanged. So okay. Atresia can occur at any stage of follicular development and will begin in different layers of the follicle or oocyte depending on the follicle stage of development. Therefore, many varieties of atretic follicles can be seen. Let's talk about corpus luteum. Corpus luteum, as you mentioned, so it starts their formation only after ovulation, and the function is production of progesterone. It's corpus luteum is formed by differentiation of the granulosa and theca interna cells. We discussed what is it in the Graafian follicle before and after ovulation. So you see, before ovulation, luteinizing hormone already started work and also already started to convert the theca interna and Graafian follicle follicular cells into the luteum cells. Its formation is stimulated by luteinizing hormone, and lifespan of the corpus luteum is finite, lasting about 12 days. 12 days only, yeah, before the next menstrual cycle, in average cycle, we mean, but in during days 14 and 26. But in case of pregnancy, corpus luteum remains. Yeah, so that it remains and became larger in size. So this is structure of corpus luteum. This cavity inside, so it in the early stage it contains blood. So because you know that rupturing of Graafian follicle is accompanied with rupturing of capillaries, and that's why blood leaks inside here, and that's why remnants of blood still remain. So here we see this network of blood from the okay, this luteum cells, it's theca luteal cells and granulosa luteal cells. So we have different derivement of the cells, but same function, producing of progesterone. So progesterone is very important in maintenance of uterus. Granulosa lutein cells and theca lutein cells. Okay, doesn't matter. So in case of pregnancy, so it converts into corpus luteum of pregnancy. So what maintains the corpus luteum of pregnancy? That you should be very well known about. So first of all, you can remember pregnancy test. So pregnancy test is based on measuring of HCG. HCG is human chorionic gonadotropin. So this human chorionic gonadotropin, it mimics the luteinizing hormone, and it is produced by embryo which already embedded into the uterus. So you see, normally without pregnancy, so luteinizing hormone has its spike, and then spike gradually slows down. But when implantation happens, when embryo already embed into the uterus, it produces this human chorionic gonadotropin, and this human chorionic gonadotropin causes the proliferation of these granulosa cells, and causes not granulosa cells, but now they're luteal cells, yeah. And corpus luteum persists, and even enlarged in size, and it reaches the 1/3 of the ovary size, and producing the progesterone, because progesterone is extremely necessary to maintain the pregnancy, and it lasts for first trimester of pregnancy. So in degeneration of corpus luteum, its name is corpus albicans. It's named as albicans because luteum cells they degenerating. So luteum cells, I mean yellow in color cells, they degenerate and replaced by connective tissue. So it's the usual process of atrophy, yeah, and it gets less blood vessels inside, and cells are not functioning. That's why cells became very whitish, yeah. And due to this white color, it's called as albicans. Albicans, it's white cells. Okay. Okay, that's it about corpus luteum. So corpus luteum, so this is the structure, histological structure. So we discussed it. So now my face just disappeared. So let's continue. Corpus luteum composed of granulosa lutein cells, theca lutein cells, discussed. Corpus luteum of pregnancy, discussed. So this is corpus luteum of pregnancy. You see how large is it? So it's takes 1/3 of entire ovary structure. So you see in cortex we see some follicles. Even with naked eyes it's visible, and with a ovarium also where blood vessels enter inside. So it's absolutely normal pregnant ovary. So cyclicity of ovary based on an average 28-day cycle. So this 28-day cycle, so it's a normal menstrual cycle period. So follicular phase. Follicular phase, it lasts for days from 1 till 13. First is the day of menstruation, actually, so you should be concerned. Follicles are differentiating and secreting estrogens. Follicular cells, yeah, I mean, follicles are developing while menstruation. So from day 1 till 4 is occurring. So these follicles start in differentiation in very first days of menstruation. Then it's follicular phase. Then ovulation, very short phase but very important phase. It is composed of process of emerging of ovum. So Graafian follicle ruptures and releasing secondary oocyte. So with the cumulus of 4 cells, we discussed it just before. And so surrounded by cumulus of 4 cells, secondary oocyte enter into the fallopian tube, in an ampulla fallopian tube. And in luteal phase is a phase of luteinizing hormone. So in which these walls of follicles they change it into lutein cells. I mean, they starting to produce progesterone. So this they predominantly produce progesterone, but also they produce estrogen too. And approximately at day 26 till 28, production of both of these hormones, estrogen and progesterone, almost stops. And due to stopping of this hormone, it leads hormone secretion. It leads to dropping of level of hormones, and it causes menstruation. So this causes menstruation actually. Oviduct. So structure of oviduct. So oviduct is a tubular structure, tubular organ, It's a pair of 12 centimeter long tubes that have 4 subdivisions. So these 4 subdivisions, they are infundibulum. It's funnel shaped, so it's a free end structure which enter into a peritoneal cavity. Actually, it's opened in peritoneal cavity, and it possesses fimbria, so by which they just surround the ovary during the ovulation process. So they just capture this ovary, and ovum releases. So I mean secondary oocyte with cumulus with corona radiata enter directly inside the infundibulum. So it directed to this area. So it has some mechanism for regulation of it. So because it attached exactly to the site of ovulation. Then ampulla. After the infundibulum, we have ampulla. So ampulla is a thin-walled lateral 2/3 fertilization. Lateral 2/3. So this here fertilization occurs, and in ampulla isthmus junction, fertilization is the most common place for fertilization. It's possible to have it even later, but still ampulla is the main region. Isthmus, it's a thicker walled, medial 1/3. So it's thicker. So presently, so most length of oviduct is composed of isthmus. And we have intramural, so thinnest part, so which is continuous with uterine lumen. So then structure of this oviduct. It contains mucosa, submucosa, muscularis externa, and serosa, same as in digestive tract. Yeah. So mucosa shows gradation from infundibulum to intramural subdivisions, exhibit complex mucosal folds that are most elaborate in the infundibulum and are sparse in the intramural subdivisions. So epithelium, so very important, remember epithelium. It's a simple columnar composed of ciliated cells that are most abundant in the infundibulum and secretory cells that are most abundant in the intramural portion. So it's pretty understandable, yeah. In beginning, so what we have to do when oocyte enters inside the fallopian tube, we need to trap it towards the uterus. So if it gets fertilized, then embryo which appeared there, so should be moved, passively moved. So because embryo has no laps, yeah, it has no their own cilia, and with the help of this fimbria, with the help of the cilia which is present in the ciliated columnar epithelium, so it moves towards the uterus. And in infundibulum, in intramural portion, we have secretory cells. So much more secretory cells. As you remember, in beginning of this semester, I explained it, yeah, that it produces uterine milk. So it produces nutritional component for embryo, and with the secretion of this components, so development of embryo might happen, is possible. So muscularis mucosa is lacking here, so because no need to constrict here or something, so just cilia is enough to move this embryo. Submucosa. Submucosa of this is continuous with lamina propria forming a continuous connective tissue layer. So actual differentiation of lamina propria and submucosa is not evidential. So because it's from loose connective tissue, very gradually it converts into the dense connective tissue. Muscularis externa. Muscularis externa poorly defined inner circular and outer longitudinal smooth muscle layers, which are thinnest in the infundibulum and thickest in the intramural portion. So nothing special. And serosa. Serosa covers the outer surface except the intramural portion. Intramural portion, it's so as the name implies, intramural, it's inside the organ, inside the uterus portion. So here it is. So this is structures, these folds of fallopian tube. So this is ciliated epithelium, columnar ciliated epithelium, which moves the embryo toward the uterus. Histological organization of the body and fundus: it's perimetrium, myometrium, and endometrium. So endometrium, actually, endometrium of uterus, it's similar to mucosa. It's also composed of epithelium is simple columnar with the cilia. It has lamina propria. It's also known as endometrial stroma. contains multipotential stromal cells and abundant ground substance, and simple tubular gland. So here we have simple tubular glands, again, so lamina propria. So, and zonation. So we have different zonation of endometrium. So the zonation is based on its functional role. So we see we have functional zone and basal zone. Functional zone, it is a zone which is changed during the menstrual cycle. So if in different phases of menstrual cycle, functional zone is changing. And the basal zone is this structure which remains unchanged during the menstrual cycle. So the basal zone remains after the menstruation, because menstruation actually is a shading of the functional zone of endometrium. So that's a main feature of it. So here we see it. So this line shows the basal zone layer. So you see, it's not changed. It has no any structural changes during the menstrual cycle. But so here no changes. So basal zone has no change. But in endometrium is changing. So now we'll discuss this phases of changing. So it gets compact. Then here appeared the glands, larger amount of glands, and then shading out of this glands. So different phases are shown here. So compact functional zone and basal zone intact. Then you see very thick functional zone with glands inside it, and then shading out of this functional zone. Basal zone remains unchanged. So that's you should keep in mind. So arterial supply of endometrium, it has two main sources of nourishment. It's a basal straight arteries, remain and supply basal zone, so because it's stable portion, and we have spiral arteries. Spiral arteries are those which depend on hormonal level. You remember we discussed it, yeah. So as more we have, so actually spiral arteries are very closely related to progesterone. So they are controlled by progesterone, and basal arteries they depend on estrogen predominantly. Spiral arteries predominantly depend on progesterone, but actually depend on both. And you remember in which phase progesterone is produced more? After 14 days, approximately, when corpus luteum is formed. And progesterone actually here causes the production of more and more amount of this spiral arteries, and they embed functional zone of endometrium. And this functional zone of endometrium is rich of blood vessels. And there in diagram it will be shown. Capillary plexus lies under the surface epithelium. So surface epithelium, under surface epithelium we have capillary plexus, so which is as in every tissue. So we have a lot of capillary networks under every epithelium for supplying of this tissue. It's also necessary for attachment of embryo to the uterus. So here the different levels of regulation of menstrual cycle. So you see FSH and LH. They are almost so you see FSH. So it has some spike during the first days of menstruation, third, fourth day of menstruation, and it stimulates the production of follicular cells. Then luteinizing hormone. It has very large spike during the menstruation and causing the menstruation, and effects of this LH continues till 28 day. So let's how it affects the follicular stages. So from primary follicle till secondary, tertiary, and Graafian follicles, development goes under the control of FSH. And during the peak of luteinizing hormone, this Graafian follicle ruptures, and secondary oocyte, you remember secondary oocyte already, with the corona radiata enter into the fallopian tube. And LH already triggers these granulosa cells and Theca interne cells around to form the corpus luteum, corpus hemorrhagicum actually, and corpus luteum. And then when LH level and FSH level drops down, nothing maintains this corpus luteum, so it leads to formation of corpus albicans. It's a connective tissue, so atrophied corpus luteum tissue. So these phases are follicular phase, ovulation, short phase, and luteal phase, as we discussed. Then you see, and during the follicular phase, so these cells, granulosa cells, follicular cells, and theca interna cells, they are mainly producing estrogen. It increases the level of estrogen before LH spike. So progesterone is produced only in basal level. But after LH spike, this gradually all the cells of this granulosa, they are transformed into luteal cells, and luteal cells producing progesterone and estrogen too. And this progesterone and estrogen is reached peak in 24th, 25th day. So it's very important right now. So later I'll explain to you. And then gradually, so when atrophy of corpus luteum happens and corpus albicans is present, so level of estrogen and progesterone drops down. So progesterone drops down. How it reflects here? So drop of progesterone and estrogen level leads to stopping of spiral artery growth and atrophy of spiral artery. They became collapsed. They became thrombotically changed, and these spiral arteries are blocked. They collapsed. Yes, they just collapsed, and no supplement of this capillary network. So capillary network of the endometrium happening, especially functional zone of endometrium. And of course, it leads to shedding of this layer. Okay, and glands and all the epithelium which present, so stroma of this stratum functionale, so functional zone of this endometrium, it sheds out. Okay, what happens next? So under the influence of estrogen, which were produced by follicular cells here in theca interna, it causes the proliferative phase from 5th to 14th day. Resemble something, yes? So also same line, yeah? And then till 14th day we have proliferative phase. So what's the proliferating phase? Actually here the mitotical division of cells happening. So you see compact, so now I'll show it to you here. So here you see compact tissue is appeared in endometrium. So here produced a lot of cells, which furtherly will be important in implantation of embryo. Okay, then proliferative phase happen. Okay, then all the cells are produced, and now we have to create something, some puffs for the embryo. And here for this, progesterone works. So progesterone makes it more loose. Tissue became looser. So here more glands are produced. Spiral arteries became more embedding inside. So the spiral arteries which are present here, they reach the maximum involvement on 24th, 25th day. And after this, if progesterone and estrogen level drops down, so it leads to collapsion of these arteries and shedding out of this functional zone of uterus. So why 24th, 25th day? So here you should remember embryology. So you see 14 day, so this 14 day happens the ovulation. Fertilization happens approximately next day, yeah, 15 day. Here we are, 15 day. Then, so then which way we should wait? Approximately 5-6 days. 5-6 days, embryo travels through the fallopian tube, and at the same time, when it travels through the fallopian tube, uterus is trying to prepare to meet this, to intercourse with this embryo. So here produce a lot of glands which are nourishmental, yeah, produce a lot of blood vessels inside. Connective tissue is here produced in large amount, and to make puffs for embryo. So please, embryo, come here and get inside, yeah. So this is what happening. This is why 21st, starting from 21st till 25 day. So we create a maximum comfortable environment for embryo. But if no fertilization happens, so no human chorionic gonadotropin is produced by embryo. If embryo doesn't implant here, so that it doesn't produce human chorionic gonadotropin, human chorionic gonadotropin doesn't maintain the corpus luteum, and no more progesterone produced, and then it inevitably comes to menstruation. So that's, I hope it's understandable. If embryo enters here, so here the production of syncytia trophoblast happens, and the syncytia trophoblast causes expansion and produce HCG, human chorionic gonadotropin. It maintains the corpus luteum, progesterone level maintained and even elevated, and then this uterus, the functional zone of uterus, remains for a long time till the birth, because it is necessary to nourish the embryo, nourish the fetus in future. So that's a cycle. That's why we have this cycle. Okay. So I hope now you understand the menses, because most of males, they don't understand why God created this torture for females, and especially girls don't understand why they created. So it's just safety of energy, just maintaining of this secretory phase in uterus all the time is not economically not profitable. So it's profitable to make it in cycle way, because maintaining all this will create some infections, will create some injuries and cancer, even cancer. So that's why it's better to change the cycles. So nature decided this like in this way. So girls, sorry. So endometrial changes we discussed. So here I hope you'll read it. You can make a stop and read it. This also you can stop and read it. Premenstrual phase also you can stop and read it. So, but in general I explained it. Structure of cervix. Cervix is the lowest portion of uterus, beginning about the extending into the vagina. It contains endocervix, surrounds the enterocervical canal. Mucosa is composed of simple columnar epithelium with cilia and many mucus-secreting cells. So, I forgot to say about epithelium of uterus. Epithelium of uterus is columnar epithelium. It is columnar, but without cilia. And in cervix we have similar epithelia, simple columnar epithelium, but with cilia and many mucus-secreting cells. So it's necessary to provide the mucus in cervix to produce mucus, so which interrupt the penetration of sperm cells and bacteria during the not in the time of ovulation. So just to prevent endometriosis, so endometritis, inflammation of endometrium. Remainder of cervix consists of connective tissue with some smooth muscle. Cyclic changes in functional cervix. So mucosa is not sloughed during menstruation. Spiral arteries are absent. So normally in cervix we have no spiral arteries. It's very important because cervix doesn't bleed. Normally doesn't bleed during the menstruation. In pathology we'll discuss later is endometriosis. So sometimes cervix is affected. Cyclic changes in the cervical mucus. At the mid-cycle, secretions are abundant and the molecules are linearly arranged, facilitating the movement of sperm through the cervix and or into the plica palmata for storage. Alkalinity of the cervical mucus neutralizes the low vaginal pH, providing more favorable environment for the spermatozoa. So normally in vagina, environment is not friendly for sperm. But in the menstrual cycle, in a 14-day, it gives alkalinity, so higher alkalinity, and mucus which blocks the cervix, so became much thinner. And at other times during the cycle, cervical mucus is more viscous, making sperm penetration difficult. It's necessary not for sperm, actually. It's more necessary for bacterial prevention to enter inside the uterus. And because uterus is a very gentle organ, and we need to diminish the time when it can be opened. So ectocervix. Ectocervix is a portion of the cervix that protrudes into the vagina. So its outermost surface. It is covered by stratified squamous epithelium, same as in oral mucosa. as we discussed a little before. Junction of this epithelium with the simple columnar epithelium of endocervical canal is abrupt and is called the external os. So you remember we discussed it, so same changes we seen in esophagogastric junction. So where abrupt changes of epithelium from stratified squamous moist epithelium into the simple columnar epithelium. Same happens in ectocervix, ectocervix and endocervix vagina, endocervix of uterus. So and in pathology, so we won't discuss, but just for future for you, we have erosions and pseudo-erosions. And main difference between erosion and pseudo-erosion is that in erosion, so we have scrabbling of ectocervix when stratified squamous epithelia is ruptured and reveals the reddish in color lamina propria of this cervix. So it's erosion, but sometimes we have pseudo-erosion. So it happens when some portion of endocervix just turned out into the cervix, into the ectocervix, and become visible during the gynecological examination. And it is also red in color. It is also hyperemic. And sometimes gynecologists, they confuse it and they make a biopsy. And in conclusion, there will be two diagnoses. So two options, yeah, or it's erosion or it's pseudo-erosion. So if it's pseudo-erosion, so it's nothing bad in it. So might be something happens. So might be something pulling, something pushing on this cervix and turn it out. If not, might be it's tumor. So but it's some diagnostic approach, yeah. So that a real or pseudo erosion is there. So this cervical canal, so you see this abrupt changes from columnar epithelium to stratified squamous epithelium. So here we have a lot of glands, Nabotian cysts. Nabotian cysts, they are they're gland secreting, so for cervical canal mucus. Vagina. Mucosa of vagina, so it's composed of stratified squamous epithelium, as we discussed in ectocervix. It also contains lamina propria, rich with numerous blood vessels and elastic fibers. Muscularis mucosa is lacking, and here we have ruga. Ruga, so same as in stomach, so it's made for expansion, yeah. So because during the sexual intercourse, vagina expanding. So mucosa is continuous with the lamina propria, forming a single connective tissue layer. So muscle layer, it's composed of inner circular and outer longitudinal smooth muscle layers, and it's also supported by skeletal muscles around the vaginal orifice. Adventitia or fullus connective tissue accumulates glycogen. No glands are present in vagina, so please remember it. If I'm not mistaken, that's it. Yeah. So thank you for attention. See you next time. So observe this video, share with your friends. Goodbye.